Hi everyone, welcome to the intro of the intro. If you want to skip straight through to Dave Renfrew and my conversation about it's not all about getting strong, so picking Dave's brain about pain and pain science and rehabilitation for painful problems, then skip through to about 33 minutes. Before that, Blake and I talk about Liz Frank injuries, peritendons, case studies of insertional Achilles, why it's important to listen to people outside of your circle, training programs with limited timelines, and probably a little bit more. So enjoy. Thanks.
And you're here with my co-host Kelly Kortick, sub 140 marathon runner and 30 kilo bench. Sub 140 half marathon runner and 30 kilo bench press in the same day. Hybrid athlete. Welcome. How you going, Kelly?
I actually don't even know if I could do the two together in one day.
Yeah, I've seen you do it in the same day.
In the same day.
And a 30 kilo bench press.
I reckon I could do that.
Challenge
accepted.
You're like the female Nick Baird, strong yet endurance based as well. You know, the hybrid athlete. There's a bit of a push for that lately, about people being able to do well in endurance events but also be strong.
I'm fast too.
You are pretty fast. Kelly is ridiculously... No, you're really good endurance wise. A good example I would use is... You're very efficient with your fuel consumption as a car, but the engine's not very big. So on the Speedo, instead of saying 220, it's like 140. But you can hold yourself at 130.
I feel fast though.
Yeah, you do feel fast. But anyway, let's get stuck into it. How you doing? How's the week clinically?
Really good week this week.
Yeah, it was good.
Yeah.
Can you tell the listeners, I know we've got a bunch of new listeners listening. Hopefully they've come this far. We don't usually intro like that, but can you tell the listeners what you do? Who is Kelly Kortick?
The face behind the voice, or the person behind the voice.
Yeah.
I'm a physio. I work at Newcastle Performance Physio with Dave Renfrew, who we actually have on the podcast for today. So you'll get to hear our conversation that we snuck in between patients a couple of weeks ago. So a really good chat that we had. I am also a runner. I would call myself a recreational runner. I love it, and I try to set myself personal goals and really work hard to achieving them, but that's probably where it ends, I would say. I love treating runners, and I love everything about running and working with female athletes. That's the area that I'm most passionate about. That's probably the most of it. I really like learning, and I like to be challenged, and I love to have a group of mentors around me all the time where I'm constantly asking them questions. So thank you to all of those people. You know who you are, Dave Renfrew being one of them again. I'm just passionate about what I do and want other people to sort of feed off that passion and continue to challenge themselves to get better and gain a better understanding of what they're doing and why. And that's pretty much why I was excited to start this podcast. That's probably the why behind why I am doing it.
Yeah, and it's grown significantly over the last, we'll say we started in February, a bit less than a year, and I did not think it would grow to a point at which it is now. I mean, we always said if one person listened and had a better outcome with their patients because of something that we talked about or said, not that they agreed with or disagreed with, we'd be happy. And it's, by the sounds of it and the messages that we do get, it's been definitely more than one, which is great.
And how incredible is it to have the conversations that we've had with the people that we've had? I couldn't imagine that having happened without us starting the podcast, and I'm so grateful to be in a spot where I can do that and say that, you know, we've talked to some of those experts in that area. I feel really lucky to be able to do that and again generate some of those conversations and be able to pick the brains of the experts in the areas that I'm really interested in. Tell us about Blake Withers.
Yeah, so I'm very similar to Kelly, but I'm a podiatrist. We've been out relatively the same amount of time. Kelly and I are actually together. We're partners, live in the same house, and maybe like each other a little bit. And so I work...
It's not when we're on the podcast. podcast. So.
Yeah, not more on the podcast. So, but I really did want to get that out there because our dynamic as podcast hosts, but also in a relationship, we probably have a little bit more leeway than if we were just friends doing a podcast together because we can...
Because we tear each other to shreds.
Yeah, and it's okay. Yes, but yeah, I work at a chief podiatry in Newcastle, so where we work within a kind of specialty sports medicine clinic with a bunch of sports doctors and sports physicians, and I work for Justin Smith, who is the owner of Achieve Podiatry, and I work and lecture at Newcastle University, teach amongst a couple of things, lecture in biomechanics, teach about diabetes as well, which I probably haven't mentioned on the podcast, and orthotic care, a little bit of rehab and strength and conditioning, and I've done my postgraduate, had one paper published, and I'm also doing some research this year looking at pain and pain catastrophizing, kinesiophobia, and how it influences more specifically foot pain.
Interesting.
Yeah, and I really like to run as well. We like to be active, we like to gym and run, and really, I guess we wanted to create this podcast to help people gain a better understanding, not of just topics related to sports medicine, but topics related to pain, strength, rehab, pediatrics, foot orthotics, footwear, running, injuries, that kind of thing. Female athletes, yeah. So if you're listening to the podcast and you don't follow us on Instagram, we're probably more active on Instagram because we only release weekly, but we generally get someone on each week to talk about a really specific topic, an area that is a little bit of their niche. Like we had Dr. Rich Wheely talking about bone stress injuries, we had Adam Diddick talking about run coaching, we've had Ian Griffiths talking about podiatry and foot orthoses and heel pain. Yeah, we've had lots of really good guests, which is awesome, and plenty more to come. Hopefully, if they continue to come and want to come on the podcast. But let's get stuck in and talk about a couple of different topics that I wanted to discuss, as we usually do. Referring to other people in different disciplines and specialities when things don't fit into the typical box. So I wanted to ask, what considerations do you have when something comes in and presents to you clinically, and it triggered my mind because this week it's been happening quite a lot, a couple of times a day, which is quite unique, where I was like, this really doesn't fit into any particular box, and it could be this or it could be that, and I'm not 100% sure. I can say that we're ruling out things that are nasty and sinister. What are your considerations for when something comes in and it's not really fitting into that box? What do you typically do and say?
Well, I can give you an example, and it's on the list of things
that
we were going to talk about today anyways. The last couple of weeks I've had a work cover patient who was injured at work, had a couple of beams fall onto his foot, and it pushed his foot into sort of like eversion and external rotation. And he had an X-ray and was put into had a fracture of his tibia and fibula, and was put into a boot, non-weight bearing, for a few weeks, and then walking in the boot, and then eventually out of the boot. And I saw him, I think, 8 weeks post-injury, or maybe it was 10 weeks post-injury, for physio to start rehabbing him to get him back to work as a labourer, or something in that sort of area. And it just sort of wasn't going as I would expect for that particular type of injury. Usually after a fracture, it's a bit stiff, and maybe they're a bit weak because they haven't been using it as much. But it tends to progress, I would say, reasonably quickly. He also had an asymmetry, so I picked up that he had a bit of like a valgus foot deformity on that affected side, and he was getting quite a lot of pain through the sort of the arch of his foot. So I got on the phone to his case manager and said, look, I think that this is something that needs to be looked at from podiatry, and I wanted to send him to Achieve Podiatry for an opinion to look at that, because it wasn't progressing as I was expecting it to, and it was really, really limiting him how painful it was on that sort of arch of his foot, that medial longitudinal arch. He ended up going back to the doctor just to have his sort of review before that, and the doctor actually had missed a Liz Frank injury.
Not the GP or
the GP. So this is through, I think this was still through, he was still seeing the GPs through the hospital, maybe in outpatients, I'm not too sure. But they had on this, so this consult was now maybe like 12 weeks post-injury, roughly. And they had missed they looked back over the scans because his presentation, like, he just wasn't improving as you would expect. So they looked back on his scans and actually found that he had experienced a Liz Frank injury that they hadn't picked up on. So that's an example of one where I wasn't confident that it was progressing in the direction, and I was planning on sending him towards podiatry. But yeah, definitely needed another set of eyes on it for sure, because that was very sort of left field, not something that I was thinking of. I kind of just assumed that that all those boxes were sort of ticked off prior, and it was more just the rehab side of things. So yeah,
it's a great example of when things don't improve, and seeing patients consistently hoping for the best and things aren't improving. I mean, based off what we know about tendons and joints and heel pain and capsulitis and patellofemoral pain, like, we've got a pretty good understanding of the general timeline. And not to say that everyone fits from A to B all the time in that exact way, but if things aren't improving after a couple of sessions, you do definitely have to question, one, obviously what you've done, but also the diagnosis and if you're treating that. And that's a really good example where it would have been quite easy, and I could picture myself as a student or even a younger grad just continuing to treat that arch pain and go, I'll use maybe the orthotics wrong, or maybe the footwear's wrong, or maybe I'd given too much exercise, or they're spending too much time on their feet, and it's going over and over it instead of going, great, I think I've done most of the things right. They need to go and see somebody else, and that could be, back to the doctor, or a sports doctor, or a sports physician, or back to the orthopedic surgeon. And it was quite interesting.
I mean, I was thinking like a tib post dysfunction, or an injury to the ligaments on the medial side of his foot or something. Like, I just
those medial ligaments.
Well, that's the way that
the deltoid ligaments, you mad snake. Spring ligament.
Spring, that's the one I was thinking of.
Spring. Yeah. Bruce Spring ligament.
So I wasn't even... Liz Frank injury was not on my radar at all. Like, completely not on my radar.
And you can imagine if you
And also not really the mechanism, or maybe, I don't know.
Yeah.
It's tricky to tell.
Yeah. And you never know with those mechanisms. You never know if someone's... Like, they're like, oh, yeah, my foot was in this position, or it was, or it wasn't. You never really know.
Yeah.
I mean, you got somewhat of an idea. But a great example where it's like... Because I always say... And that's how I kind of justify it to patients. And I wanted to hear how you would say that. When I'm not sure, again, when I was younger, I'd very much try and bluff my way through it. Probably, but now I'm really transparent and say the reality is it's not fitting into any specific box. I want to be really confident that we can rule out the nasty, sinister stuff, and I think you need to go and see this person, or you need to go and have this imaging, and it may be an MRI or something along those lines, but more commonly I'm sending it to someone else, and I'm always explaining and saying, the worst case scenario that not the worst case, it's a really good, it's very likely that you'll go and see them and they say, yep, everything's really fine, just go back and continue to see the health practitioner that you were seeing and treat it this way. Or they might give you a couple of suggestions. Or on the flip side, they might say, oh, no, this has been missed, or this is really unordinary or unique, and that's a great pickup by the podiatrist or the physio or the chiro, and then they can treat it. And the really extreme example is like a tumour or something like that, and they do present, or a stress fracture or something like that.
Yeah, I agree. And with this case in particular, I was very transparent. I was like, look, this doesn't seem to be progressing as it previously was, as I was expecting, You have an asymmetrical foot type, and I don't know if this is something that you had prior to the injury or if this is since the injury. And he was like, yes, I've noticed that too, and I've been trying to look back over old photos
deformity.
To see if that was something that I had prior to the injury, and I can't zoom in close enough because that's something I'm concerned about too, especially because that's where the pain is. And I was like, yeah, look, I'm not sure, so I think we just need to get another set of eyes on it, either a sports doctor or podiatry. I think at the time I was more inclined to send to podiatry because I thought it was more of a valgus deformity and tib post that could be managed by podiatry. But I think hopefully it has a good outcome now that we're a bit more on top of things. Yeah,
and that really leads to the next thing that I wanted to discuss and talk about with you is, and I've titled this little section, people are smart, they very likely know stuff that you don't. So I saw someone this week who I had originally saw for some big toe pain, whether it be some arthritic change or more of a capsulitis, a really keen runner who did UTA 50 and planning to do UTA 50 this year, and also is it 6 foot track as well. So they represented. Big toe was fine, which is awesome, but they had developed an insertional Achilles tendinopathy or tendinitis because it was quite acute, and we were going through all the things that we would typically expect of a tendon. You know, it's sore for that fast rate of loading, things like elevation, flare it up, fast running, flares it up. And when someone's in a highly cushioned shoe, depending on, you know, their biomechanics and anatomy or their BMI, they can sink into the shoe a little bit if it is really cushioned, and that can actually rub and irritate on the back of the Achilles, which was so interesting. Like I had no idea, and that had never crossed my mind, and it made me think of all the things that people know, and because they don't talk for reasons, whether it be on social media or they just don't collaborate and discuss amongst themselves, there's so much knowledge out there in people's brains if we all just talked and discussed. What do you think?
Yeah, I like that, and I agree with that. I think of, you know, tendons in the body are the springs of the body, and for them to be springy, they need to create stiffness, and if they're in a really spongy shoe, it's harder for them to create that stiffness to then explode out of, or to develop that sort of energy storage and release. So I think a harder shoe allows tendons to work more effectively, I think. But that's me just being a bit arbitrary.
Are you adding to what I said? Or?
Yeah.
Oh, yeah. Because you know I wasn't talking about that.
I know.
Oh, cool.
Oh, wait. Yeah, you were saying that it irritates the tendon.
Yeah,
being
because
in a squishy shoe.
It may. So if the shoe...
I'm contributing to the squishy shoe aggravating a tendon. How do you know if it's the mechanical rubbing? I didn't say that. Give me a break. I just thought you were just saying something completely different. I just had never thought of that, ever. Never crossed my mind. And I just thought, wow, you know, and I always do think that, and why I try to communicate and talk with so many other clinicians is because people are usually knowing a lot more than what you think they know, or they know a lot more in regards to what you know. Anyway. I was trying to give you the silent treatment.
Anyway, and so a good example with this person as well, we were talking about what would be the aggravating factors for an insertional Achilles, and the two big ones, and this person runs on the trails, the two big ones are elevation, which is going into more dorsiflexion and then irritating the insertional fibers, and then also faster running. I had assumed anyway, as we were talking a little bit about how we're going to modify some of their training in the short term, we were going to try and reduce the elevation a little bit and then try and reduce the faster running and keeping it at a slower pace. And funnily enough, just listening to them, they had done some faster runs in the past couple of weeks and pulled up fine, like really no pain after, no pain the next day, and it felt really okay. And it made me think, and I know this person runs on their forefoot, it made me think, just because of what I've read, I'm like, great, no fast running or less fast running, but if they didn't have any irritation and we know that tendons talk to us the next day, was it smart of me, or do you think it was the right thing for me to say it's probably okay to keep all the faster running that you're doing because it seems like it's not aggravating you based off the symptoms you're reporting? And I thought, maybe why would that be the case? Like biomechanically, and I guess if you're running on your forefoot and you're in that stiffer position, it's almost like doing an isometric hold. That's what I was thinking.
I've often found mid-portion tendinopathy to be more aggravated by the faster running, and insertional Achilles tendinopathy to be more aggravated by hills and things.
Positive presentation with hopping and jumping, but the faster stuff felt okay. So it's a good example, I thought, where I would have said, let's cut that. But in reality, listening to them talk, it's like, no, you can actually probably still keep most of it because it doesn't seem like it's provoking you. But on the flip side, the elevation did, so that's what we reduced. Not took it away completely, but reduced.
That's a good way to keep loading it and using it and keeping it strong and resilient and having that energy storage and release in their program by maintaining that faster running.
Yeah. Yeah, I agree. Did you have any highs and lows to talk about? You just kind of sit down and just wait for me to ask you questions. Hey, do you have anything to talk about?
I had a question for you, actually.
Yeah. And the reason, everyone, for you listening, the why I say all the topics is because I usually write them down.
I contributed to this list.
I said to you last, like, the things you think about, because you always ask me, how do I come up with these topics or little bits? And I'm like, every time I think of it, I write it down straight away so I've got it for when we record it.
I think of it,
and
then I don't
just
put
goes
it anywhere
away.
and then it just disappears. But I do have a question.
Yeah.
Or a case.
Yeah. Yeah.
So, I have, at at the moment. I have a patient who is doing the Camino walk in Spain, France, Europe in April. She has a pretty moderate to poor training history at the moment. So the Camino...
What does that mean?
The Camino is a hike. One sec, let me just explain this.
Right.
It's a hike that she's anticipating will take about 50 days. It's around about 20 kilometres of walking every day on trails with quite a lot of elevation. Anticipating that'll take about 7 to 8 hours a day.
Wow.
Carrying about an 8 kilo pack.
Yeah.
So over the last few months, she has been walking for maybe like an hour here and there. And the biggest walk she's done is like 3.5 hours, I think. So she wants me to program for her.
Program the walking.
Program her build towards this walk.
Yeah.
Over the next, less than 3 months now, February, March really, so 2 months. What would you do? Is my question.
Programming wise?
Yeah.
Yeah.
I've kind of come up with a plan. I think the challenges that I'm
can't ask me what to do and then just say.
I'm just saying the challenges, I think, is how do you appropriately build without overloading someone that doesn't have a pretty extensive training history?
Yeah.
What do you reckon?
Yeah. Considerations. Definitely having the tough conversation of what the reality is of increasing tissue capacity, and always the balance between making someone stronger but running the risk of an injury. That's really important. So after having that conversation, I guess really all you can do is try to build as appropriately as you can. I mean, there isn't really anything that you can do that's going to make the tissue get stronger quicker. And I don't think that you should run the risk of trying to build someone quicker and running the risk of having an increased risk of injury, which would then ruin the whole trip really anyway. So I think nothing really changes. I think it's just programming as normal. You may try and push the boundaries a little bit, but then on the flip side, you could also increase their risk of injury. So the reality is we can only get you so far in 3 months. We can try and push a little bit harder, but the risk of injury goes higher the harder that we pushed, and it's probably more appropriate to even go a little bit less because you don't want to get injured before this big walk.
But what about the risk of injury during the walk? 50 days is a lot.
Yes. So it seems
it's
though
not
you
like it's an acute spike in training load, like it's 50 days worth of walking.
Well, I'm thinking you would rather develop a niggle or get injured on the track on the 50 days rather than before, because you've got a more likely chance of finishing it probably if you get injured on the track than before. So if you get injured in the next 2 months, then it's like now I've got to go into it injured, and then you've got to have a month off or have some time off or whatever it may be, then going into the track. Whereas if you do it a bit more conservatively, at least you know you're less likely to get injured, and then you can start it feeling somewhat healthy, because you know you'll be stronger than now. But you need to get, the most important thing I would say would be getting to that start of the track not injured and feeling healthy. What do you think? Do you agree? Disagree?
Yeah, I guess so.
They're hard though. They're really hard.
It is hard.
A similar example, I saw someone before UTA 50 who had I'll just say forefoot pain for a really long time, over several months, and the UTA 50 was in a week, and we had to manage it and treat it. So yeah, those ones are really tricky, and there's really nothing that you can do. And I would encourage all the listeners and clinicians listening to this, because you can feel, and I don't know if anyone else feels like this, but sometimes you can feel really bad because you really want to help these people, and usually it's an event or something, and we like to run and do those kinds of events, so we're like, we really want you to do this well and get there injury free and not get injured, but you can't really change the reality of what's presenting.
Yeah, I think I like what you said, that having that tough conversation at the start.
Thanks for that.
I think that's important.
Yeah.
She's also coming and doing some strength work as well, which I think will be valuable.
Just heaps of toe intrinsics.
Yeah, lots of that.
And lots of abducted digital into my strengthening.
Yeah, foot core.
Foot core, yes.
Foot yoga.
Foot core. Don't need anything else, just foot core and static core.
And foam rolling. I learned today that foam rolling your quads and your hamstrings increases core strength?
Hypothesized.
Well, I think you can argue that your core strength increases by moving, because your core kind of just probably switches on, activates.
In what subgroups though? Because that's not for everybody.
If you put an EMG on your core,
you're really going to bring EMG into this.
Well, this is what the study. That's how the study tested it, was with EMGs. If you put an EMG on your core and you stood up, you would get EMG activity on your core.
Yeah, but EMG activity isn't a good surrogate for strength.
We'll talk to the authors of this paper then that says quadricep and hamstring foam rolling improves your core strength.
They didn't say that. They didn't say those exact words. Did they say it may?
No, it does.
It does. And were they saying it, or did they have a reference of a study after it? No,
this is the study, 2022, freshly out of the books.
Yeah, we'll be reviewing it next week. Are you sure that they said that?
Yeah, I'm certain. It's referenced in that other article that you were posting on social media about the 18-week injury risk reduction program. I was reading that one, and then it said how to comment on that, and then I went into that study and read that one, and I'm skeptical.
Yeah.
As to just what, I don't know.
Yeah. Well, let's finish it on a good case study to talk about of the peritendon and an insertional Achilles. Now, we know that they can happen in combination. What one would you manage first?
Peritendon.
And why is that?
I think of it as more of an acute injury that you can calm down quickly and then get onto the tendinopathy. I think if you try to treat the tendinopathy first, you're just going to continue to aggravate the peritendon and get nowhere with either of them.
And what's the primary treatment for peritendon?
Rest, really. Or avoiding aggravating factors, maybe some anti-inflams.
Yeah. Do you do the wrap?
I just tell them to take anti-inflammatories usually. Yeah.
I've been doing had 2 this week, and they've gone okay with the wrap. One, actually, I saw at the start of the week, and I saw one of her family members, and then the family member come back, and she come back as well, and I was like, how did you go with the wrap? And
just explain what the wrap is for people that
yes, sorry, I was actually meant to explain that, but then I got sidetracked. So the wrap is, it's based off this study, and I still can't find the study. I think it was in the 1980s or 1990s. I know Ebony Rios talked about it, and she's posted about it, but I couldn't find it. But basically, it's Hydroid cream and Voltaren cream, which is an anti-inflammatory. You lather it around the tendon, so you mix them together, lather it around the tendon, and then wrap the area in Glad wrap and sleep for that for 7 nights. And the idea is it's meant to try and settle down.
What's that first word that you said?
Hydroid.
Yeah, what's that one do? Is that just an anti-inflammatory?
The Hydroid cream, no, it's a vase. Let me look that up now. I don't want to butcher it because I did look that. Is indicated for the treatment of superficial thrombolytis and the soothing relief of superficial bruising and hematoma. How quickly does
that? Is that what phlebitis
brings a marked anti-inflammatory effect. So activates the blood circulation, promotes the absorption of hematoma and the reduction of swelling, alleviates pain and makes the feeling of tension in the affected area disappear. Promotes the regeneration of connective tissue.
I need to put that on my bruise.
Sounds like we're trying to market this cream. But yeah, so you get that from the chemist. It's about $16.99 from Chemist Warehouse at the moment. So that plus...
Use code Blake and Kelly, get 10% off.
Yeah, and it seems to work incredibly well. And then, like you said, managing the aggravating factors and trying to really reduce the shear force. So when you said relative rest, like... heavy calf raises and running and things like that tend to aggravate it. So, you can do calf...
Isometrics.
Yeah, isometrics tend to work well. I haven't seen one really chronic one. Have you ever managed them for a long time? They tend to settle down pretty...
Yeah, I think they settle down reasonably quickly.
Pretty quickly, yeah.
But you also need to sort of deload them from swimming and cycling, like that, when Blake said that shear or friction sort of force, like even those kinds of movements will aggravate it as well. So it's often a bit of pulling back, but not for long. I'd say like a week maybe, if that.
Yeah, and it like for the listeners, a very simple diagram. You imagine a tendon, and then you imagine a mask of fluid around the tendon, which is it synovial fluid? It is synovial fluid, isn't it? And then on the outside of the fluid is the tendon sheath. So a peritendon is when
I don't know if it's synovial fluid.
Yeah, that's more in the joint.
Synovial's in the joint.
Yeah.
I don't know.
Yeah, I don't think it is either. I have to look that up. But basically the fluid inside is inflamed and angry. Is that right?
The sheath.
The sheath. The sheath is inflamed and angry.
I think so.
Yeah, or a combination of both. It's very hard to dictate which one's irritable. But I do know in some cases as well, and I have seen it, where they actually inject PRP between the sheath and the fluid to help it. But I've, not seen it regularly enough to see any really long-term good outcomes. Seem to work, but I haven't seen it enough to say, it's definitely something that we can look at later. Anything else you'd add to that? So treat the peritendon with what we just said, and then insertional Achilles just as you would treat any typical tendinopathy, I guess. Yeah, but consider of finding out for the person in front of you, what's the aggravating load, because it might not be what you think it is. For an example of that runner doing faster running. Yeah, cool. Anything for the listeners? For your part ways, we wanted to say today. We wanted to give everyone a challenge to do a clinical challenge, but we didn't really talk about what we wanted that to be. You've got one?
Well, maybe just carrying on from our conversation last time, our little debate. Try to, or maybe I already said that last time, I can't remember. Try to really listen to your patient and not be tempted to write down their entire subjective history the whole time. Justin gave us some really good feedback on that little debate as well, and he said, often when people sit down, what did he say? They have a big brain dump of what they want to say to you, what they've been thinking about, what they've been potentially ruminating about in regards to their pain and their injury. So they'll sit down and they'll do a big brain dump. Don't be tempted to write notes during that big initial brain dump that people will give you. Try to just sit and listen. Don't interrupt them. Just let them talk for as long as they need to. And then from there, going through your subjective history in a nice sort of methodical order, and jotting down notes such as like their training history, their medical history, things like that as needed. But the big important stuff, I'm sure you'll remember that if you just listen to it.
Great, good challenge, and enjoy this episode with Dave Renfrew.
Hello everyone, and welcome to another episode of the Sports Medicine Project. So a bit of an impromptu podcast that we're recording today with a return guest, Dave Renfrew. Thanks for coming along.
Thanks, Kelly. I don't know how I feel about being called impromptu, but anyway.
Yeah, just pulled him in off the street just for a bit of...
Highly anticipated, long-awaited return of the one and only. Now, if I was introducing myself, that's how I would introduce myself. Just a little, learning curve. When you have guests with the ego of such as mine, that's how you do it.
I don't have to be polite to you. Or maybe I do. This actually is long awaited though, and I will say that because I've been wanting to record this particular podcast since I picked your brain about my hamstring. Do you remember when I was asking you about my hamstring? So, bit of a background. I'm not sure if I've ever talked about this on the podcast, but I've had bilateral proximal hamstring tendinopathy for probably about 8 years or so. And a few months ago, it started to give me the shits again. And so I was chatting to Dave about it, and it's always really interesting sort of reflecting on your own injuries and then trying to sort of rationalize treatment for yourself. But we got into a lot of interesting topics that got me thinking a lot more about persistent pain management. And I wanted to talk to you in relation to that about, it's not all about getting strong, and the context to that being the fact that, at that point in time I was deadlifting 70 to 90 kilos and running my personal best for half marathon. So functionally and strength wise, I was tolerating quite a lot, but couldn't quite figure out why I was still getting symptoms, and just felt like I needed to keep strength training and getting stronger and stronger and stronger, and that would help, but maybe not. So yeah, that's kind of what we're talking about today.
Mm-hmm.
So from that, I guess let's just lay it out there for a start. For the sake of this podcast, we've ruled out any red flags. We've ruled out anything sinister or nasty. We're dealing with patients who have had persistent pain for, let's just say, sort of over 12 months or so. And yeah, taking away all the other stuff that it could be and talking more explicitly about pain that's been around and we don't have a structure, I guess, to attach it to. So something that we often talk about, Blake and I, a lot on the podcast, and something that I probably see popping up a lot on social media is, us talking about load tolerance and capacity building in the management of pain. And so a narrative that, I would often find myself saying is if we can increase someone's capacity to be able to tolerate more load, then that should be able to allow them to be able to do things without as much pain. What are your thoughts on all of that?
Yeah, I mean, I agree. Like, their load capacity and tolerance are things I'd probably say 15 times a day. I think where sometimes we get a little bit, as therapists, we can get a little bit blinkered, is that we're presuming that means physical load. So load is a word that means everything, right? So, and when, getting stronger is if you've been in pain for 12 months, you could probably guarantee, that at least statistically, that most of those people aren't at their physical peak. So getting people to get a bit stronger isn't a bad place to start. The danger is if you're saying that you need to get stronger to fix it, implying that the reason it hurts is because you're not strong. And I think as therapists, we get ourselves into this very narrow lane of cause and effect. And then if it works, great. But if it doesn't, then we're in trouble. Mm-hmm. And that's where exercise is no different from manual therapy or hot rock massages or Reiki or whatever, in that if you think that there is only one possible way for things to work, lots of things work, inverted commas for the sake of the podcast, lots of things work, but not because of how we think they work. People get better, which is good. So then you think, well, I'm amazing. I've fixed everything with this awesome strength training that I do. And then you get people that it doesn't. And you're like, oh shit, what do I do now? And that person is probably worse off. So load tolerance and capacity is a good thing to think about, but you just have to make sure that you're thinking of the very vast and wide-ranging options that you have when it comes to what loads can't they tolerate, where do they need more capacity, and making sure that you're talking about their capacity to tolerate the loads that they need, as opposed to some objective measure of strength. Strength is a metric of physical load tolerance, but there are so many different ones. And it's it's a heuristic. It's an easy thing a little shortcut, a simple concept. The person in pain gets it. It's pretty easy to run with. So you can see what happens, but we've just got to be careful when we're starting to simplify very complex things, because if we're wrong or if we're not right, maybe, then the person is probably worse off and we're confused as shit.
Do you think that it's something that you can identify from the start of the consult, if that's going to be the way that someone needs to go, or do you think it's the way that you explain it that needs to be different? Do you know what I mean?
What was the first part?
So do you think someone comes into your consult and they have had persistent pain, from the start do you know that they aren't going to be someone to just need to get stronger or increase their capacity? Or do you think that you're still going to do that, but you're going to just explain it a bit differently? Or are you going to explain it differently for everyone?
That one. So I think of where I'm up to now in terms of what I try and think of is I try not to think of what's going to work, because with complex, long-standing pain things, I don't really know what works, and you don't know until you get into it. So rather than thinking this will work, I think of where is the potential upside and where is the potential downside. So if from the start I keep my definitions of load and tolerance and capacity very open, then theoretically down the track I could suggest someone needs to see a psychologist because that's their barrier to getting to improving. So that I haven't chosen a path that I can't return from. So very early on, I'm keeping my definitions of what that means very broad, and that then fits in with my explanation of why pain can do what it does and why it's weird and why it's hard to predict and hard to get rid of sometimes. What I try and do is make those things then, like what we pick and what we choose to do, very specific to the person that we're talking about. That doesn't mean that I don't try and make most people that see me physically stronger. It just might not be the target that it is. So the mechanism may be the same. I may get them to try and lift heavier things, but the reason for that isn't to get their hamstring stronger, where if they tore their hamstring, then it probably is the reason I'm getting them to do that. So in my head, I've got it quite broad. I'm quite conscious of how I'm presenting that to people, and knowing that sort of sounds pretty vague, having that conversation with people early that, yes, I know this sounds a bit weird and wishy-washy and we don't, yes, it hurts, but I don't really have a big name for it. But that doesn't mean we can't be quite specific on what we're going to do now and what we're going to do next, and getting you to what you want is 100% possible. And most people go for that. They don't need the specificity that we think they need, particularly in this situation where we're confident that we don't have some very specific pathology that we need to address.
Yeah. So what do you think is the role of capacity building from a strengthening point of view, particularly in the management of pain in someone who is already somewhat strong? Like they're not demonstrating deficit side to side, or they're not, I guess, quote unquote, weak for their activity. What's the point of it?
The reason I like it and the reason I think it, again, I'll put inverted commas around works, is in where a lot of the effective pain and where a lot of the narratives around pain come from. So I like encouraging people to do things that they think they can't, or they've been told they shouldn't, or that challenge their preconceived ideas around reality. So, and this is where I think persistent pain does change, in that the meaning of it or the way that they perceive it changes for some reason. And I think to get that change, they need a type of stimulus. There needs to be a catalyst to cause their system to adapt in the direction they need it to adapt. As a physiotherapist with a clinic with lots of barbells, the easiest way to do that, particularly with lots of painful problems like backs and necks and shoulders and knees, is to use that to get them to realise that their previous reality is not the way that, the objective reality is different to their previous subjective reality. The quickest way to do that is to get them to do something very safe that they think they can't do. That is influenced by a lot of the narratives around why things hurt, and the fact that, you know, lifting things is bad for you and bending your knees under load is, you know, damaging, and all these narratives that are around pains. That doesn't mean that everyone gets that, but it's just a low-hanging fruit that is pretty easy to start with. But again, I think of that load and adaptation process and capacity building as a bit of like a starfish with different legs or arms. Do starfish have legs?
I'd say so.
Legs. Let's run with that. If anyone knows whether they're arms or legs, please write into the Sports Medicine Project. So they'll have a leg that's completely fine, but they'll have a leg that's been cut off. So they've lost that. So they need to get it back. How do we get that back? But that might be their confidence to do something. That might not be the strength of or their ability to lift something off the ground.
Mm-hmm.
So if we're only in one leg, with the way we think about it, if that leg can't get any bigger, then we've got nowhere else to go.
Mm-hmm.
So we have to go somewhere else. And we can still use those things to expose a system to a stimulus, but we're targeting something different.
Yeah.
And honestly, I think with what we do in here with persistent pain is we use physical loads to cause non-physical adaptations.
Mm-hmm.
And then we help people explore that alternate future to the point where they are happy that they can do what they want.
Yeah.
And how that works, I don't think anyone knows that.
Yeah. So for an example, let's go a bodybuilder who's had persistent shoulder pain. He's had scans that have ruled out any cuff tears or anything like that, and maybe it's just showing a bit of rotator cuff tendinopathy or something like that. He's had pain for over 12 months, but is still doing everything in the gym, so benching, overhead pressing, and wants to be able to continue to train without pain. How are you approaching that? You've done testing, and he's not weak in rotator cuff testing or really anything that he wants to be able to do. How are you approaching that, given the fact that he is still strong, and does he need to get his capacity higher, for instance?
It's always a tricky question because there's lots in that case study that you wouldn't get unless you started talking to that person.
Mm-hmm.
So when you start talking to an individual, you get things that they say that lend themselves to that's probably where I should start, particularly around what does he think hurts, why does he think it hurts, where does he think it comes from, if it hurts, does he think he's damaging himself, blah, 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 blah. So there's lots, in a limited case study, there's lots left on the table there that you can use to your advantage. The other thing to remember too, when we're talking about exposure, is that maybe sometimes the answer is to reduce that exposure. Maybe with this guy, the education is, well, how about we just dial it back a little bit and let everything calm down and see if that changes it. And then, presuming that we've done that and it made no difference, and we've got all of this lovely information from him that we completely understand where he's come from and why he thinks the way he thinks, and he's also then come to understand that yes, it hurts, but no, he's probably not going to damage himself. Which does happen. Like I'm fairly optimistic that a lot of pain problems that I see will change, but you have to realise that some may not, because there's either something there that no one knows about yet, or sometimes it just doesn't, and I don't know why. He has a choice to make. He can keep training and it might hurt, or he can try and modify his training so it hurts less. But he's the one that feels it. So he has a choice to make. Does he want to train, or does he want to be not in pain? And again, I'm presuming that there's a dose-dependent response to his pain. If it makes no difference, then screw it. You may as well train as much as you want.
Yeah.
But presuming that the more he trains, the more it hurts, then he has a choice to make. And I also think that there's something that happens in that moment and in the ensuing moments after that, when someone makes a choice that training is more important to them than how it feels. Something happens that then makes it more likely that it probably won't hurt in the future. But that's a tricky area to navigate, because there's lots of have all the tests miss something? Is there something there that explains it? Is there something else medically that explains it? There's lots of question marks in situations like that.
Yeah.
Which is why having a recipe to do in a situation is hard, because unless it's that same situation again, the next person, even if they're a bodybuilder with shoulder pain, will be very different. So I think having a process to work through, almost like you're coming from the other end, is a more reliable way to make sure that you're probably in the more correct area.
Is that a conversation that you're usually having early or later, once you've tried a lot of things?
As in, this might keep hurting?
I guess, called kind of giving patients the ultimatum of you can keep doing what you want to do and it might hurt, or you can stop doing what you want to do and to help it feel better.
That conversation is probably a later conversation because you're trying things, presuming that things will change at some point.
Yeah.
And if they're not changing, then it's because it's a worse conversation. Mm-hmm. It's a bit of a, well, this is the way it is. And talking about it now briefly, that's not how you would have that conversation with that person.
Yeah.
But that is a later conversation. In this case, at the start, you're more talking about, well, what's more important to you? Do you want it to hurt less or do you want to train more? That's about the extent of it. But down the track, it's a bit more of a state of the union. This is where we're at. Mm-hmm. What do you want to do? Because sometimes with these painful things, it's a bit of we get to the point where we're like, where we go from here, no one knows. Mm. So, in saying that, I often am saying to people earlier, like, no one's had this is your pain problem, no one's had it before. So what we do is, you're the expert because you're the only one that knows what it feels like. What we do is guided by you more than me. So I'm often saying that to people earlier, but that type of conversation is probably a later one. Yeah. Because it's a bit more brutal.
Yeah. And so, like, when we are incorporating exercises and potentially resistance training for painful problems, would you say it is mostly around exposure in these particular cases than in getting them stronger?
Yeah, I think there's more that happens to a system outside of the physical changes, definitely.
Yeah.
Well, when I say definitely, that's definitely my opinion. I mean, I think you can be confident to move forward with these painful problems, but you have to have a certain degree of uncertainty because we just don't know. Mm. So it's a paradox that you can be confident to move into things that you don't understand. Mm-hmm. That sounds weird, but so it's a bit of a combination. It's like, again, it's that thinking of, rather than thinking of what works, you know, lots of things could work and lots of things won't work in another situation. So I don't think of working. I just think of what's the upside and what's the potential downside. Mm-hmm. And getting people to do more of what they want has very little downside. Mm-hmm. Outside of the potential to make them more painful.
More painful, yeah. How... Like, do you think that we have a bigger role as clinicians than just in exercise prescription for pain management?
Yes.
What do you think the bigger roles are that's not exercise prescription?
Well, exercise is just a thing. And it's a thing that, you know, there's lots of things wrapped up in why we do that. Exercise is good for people. And you know, our physios have been, until we sort of took our eyes off the ball a little bit, have been those in control of exercise prescription. Obviously, exercise physiologists now, in pain anyway, like it's largely the same. Mm. Occupational therapists have been doing this, maybe not, again, inverted commas, exercise, but activity-based stuff for years. So I think limiting what we do to only prescribing exercises is it's a pretty limited view of what we can do. Mm. In a private practice as we are in now, the vast majority of people that we see that have chronic pain, if I use my inverted commas again, have like you, like the bodybuilder. They're not crazy. They're not wildly disabled. They're not avoiding things in their life. They just have these things that hurt and they'd rather they don't. Mm. And so my favourite question to ask someone is, why do you think it hurts? And by far the vast majority of people who have seen maybe 3 or 4 professionals by the time they get here, the answer is, I don't know. So if we're dealing with people with painful problems, our main role is as the facilitator of them understanding what the hell's going on and finding the answer that they need. And the current model of healthcare is like GPs just don't have the time to do that. And the vast majority of painful problems don't need escalation to high levels of medical specialty. A lot of them, if they had answers to those questions that were more accurate earlier, I think they get better faster and they don't end up with as much prolonged disability as a lot of people do. That's then beholden on whoever that allied health practitioner is. I don't really care what they're called or what degree they have. That's beholden on them improving how they deliver those primary services to that person, which is a major role in why pain becomes persistent, in my opinion.
I guess it's tricky though, hey, because if someone's had seen a physio for months for a shoulder problem and it hasn't made any progress, like the case that we were talking about, the next step kind of is to escalate that to imaging or a sports doctor or further investigations and diagnostics. So there's kind of no choice but to have to go down that path of seeing lots of people and maybe not really getting answers. Do you agree?
Conditional on the physiotherapy care being delivered, being likely to deliver a positive result.
Yeah.
So there's lots of things within the scope of physiotherapy that have a low probability outside of natural history of improving situations. So if that person has been exposed to the type of allied health care that is more likely to provide a positive response and it hasn't worked, then 100%.
Yeah.
And maybe there's a case for that escalation to happen earlier in certain cases, definitely, because bad shit happens. Things that hurt could be nasty, absolutely. Just in terms of a numbers game, though, the amount of people that have persisting pain problems, that most of them do not have undiagnosed pathology. That's just the stats. And this is where it's tricky as a clinician. If you're the second or third person, what do? Do you presume that, because you've got, probabilistically, it's easier because seeing that person at that point in time is conditional on the first two not working. So you know that that didn't work, however many iterations of it. So why didn't it work? Didn't it work because they don't understand it, or they picked something that doesn't work, or the environment was wrong, or because they've got this nasty thing that no one's picked up on? Which one is it? Don't know. So again, that comes back to having this process that if you put this person through your process, you're more, and that process is reliable, you're more likely to get to a better answer.
Yeah, I like that. That's a good answer. What's a nice common sense approach, do you think, for clinicians listening who don't have much experience in the management of complex, painful conditions? That's a very difficult question.
Well, probably, and it's not trying to trivialise people with these problems, because often they are complex, but they're not complex in terms of what you need to know about pain. So I think a lot of people let what they feel they don't know around pain and how it works and blah, 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 to get in the way of what they do know about how people get better, and probably the base rate of lots of nasty things, or the base rate of things that exist in the population that lots of people are running around with that don't have pain. So they know these things around what helps, or what gives you more chance of having a positive outcome, which has got very little to do with what treatment necessarily you pick, unless you're picking stuff that clearly doesn't work. So I think chronic pain people or people with chronic pain are different because we make them different. What if you thought of them as so you're a good example. Like, you had chronic pain by definition easily, but you could just treat it like a hamstring tendinopathy. Why would you do it any differently? So the specifics around how you treat it come from the person that has the pain. So my common sense advice is to probably stop treating chronic pain people, like even stop calling them that.
Yeah.
Like just stop making them different. There a lot of people that I have seen over the years that have had pain for years get better fast. A lot of people that I've seen don't get better fast. A lot of people that have pain for 2 days get better fast, and a lot of people that I've seen that have pain for 2 days don't get better fast. There's no prediction that you can make about pain that has any basis whatsoever.
Yeah.
No one knows what's going to happen at all. The thing you've got confidence with is that most things aren't nasty, most things get better, and that these sets of things are probably more likely to get you a better outcome, and that's just nuts and bolts physio stuff. Don't be a dick. Encourage. There's like 11 in the Lynn article from a few years ago. 11 best practice guides of musculoskeletal care. Just do that, yeah. And probably have people in your network that can check your thinking, because you will be wrong at some point in time. I can guarantee it. And if you don't have a way to check what you're doing, and you make a mistake with the person that has the nasty thing, that's not good for anyone.
Yeah. I remember that was one of the first things. I think that was before I even started working here. Maybe it was on the Iron Review course. I think you said, just like, it was one sentence, and it was like, stop treating chronic pain people like chronic pain people, in quotations again. Just treat them as you would treat anyone with an acute injury, really. And I think that was very useful for me to start to think about those persistent pain cases like that, and I still use that a lot today, so I think that's a really, really good advice, and I think it's helpful.
The reason I probably came to that was because I used to treat them differently, and I've just heard heaps of, and this is often a criticism of clinicians who employ modern pain education techniques, if that's a PC way of saying it.
Well, yeah, I think that's what I fell into.
Yeah. That they try and explain pain with a capital P to people, and people are like, what the fuck's this? I don't give a shit. Like, that's not me. What's going on with me? And this was last week. I had a lady come in who had done, she'd had a physical injury to her ankle, and it just went weird, as sometimes they do. The bone injury had healed, but she had this ongoing weird, strange pain. So she was admitted as an inpatient into a private hospital to go through their pain rehab. And she said, I've read all that man's books. And I said, who are you talking about? She said, the one with the funny name. I said, Lorimer Moseley. She said, yes, I read his books and they're all bullshit. And I'm like, well, when you were reading it, what did you take from it? And she's like, all it is telling me that it's in my head. So that's an example of information that has been applied incorrectly for that person with a negative outcome. So fundamentally, she didn't understand those concepts and how they related to her. So they just seemed to be some alien thing, which she took as someone trying to convince her that her ankle pain wasn't real. And that's when, so that's not I think Moseley and Butler's work should be criticised, as should every work. It's not perfect. And all of these things that we come up with pain are current models, which we need to update as we go. But information around pain is is sort of a bit useless unless that person understands how it relates to them.
Yeah.
And that comes to your ability as a therapist to converse and talk with people about stuff that's a bit uncomfortable. Well, certainly physically uncomfortable for them, but it's hard to talk about stuff where, like, I joke to lots of young physios that I talk to all the time. I make people cry all the time. It's not because I'm mean and I push on things that hurt, but I get them to talk about the impact that shit like this has on their life, and most people cry because it's fucking shit.
Mm.
So that's the hard bit. And they don't need a cuddle and a cup of tea. They need, okay, that's shit. Let's try and make it better.
Mm.
And so that's the bit to get comfortable with, the uncomfortableness of it and the uncertainty around it.
Yeah.
But you don't need to be the smartest person in the world to do that well. And any course or anything that I do, the last thing that I say is that you, particularly younger clinicians, is that you could be the best person in the world for the next person that you see that has persistent pain. You could be the best fit, not because you know the most, but because you get them and they like you and they trust you and you know what you're doing and you're confident with what you're doing, but you're not so overconfident that you don't ask for help and blah, 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 blah.
Yeah, that's good. I like that. And then what about from the other end? So if a patient is listening to this, what's your advice to them if they have been experiencing pain for a long time?
Ask yourself my favourite question. Why do I think it hurts? And if your answer is, I don't know, or if your answer makes you feel weird, like, I don't know about that, if it makes your guts churn, or it makes you start to ask questions about it, ask someone else.
Mm-hmm.
Keep asking people until you get an answer. Understanding that sometimes the answer is, I don't know, or the answer is, it's this, but no one knows how to do anything about it, which those things exist.
And when asking other people, you mean like their aunts and their uncles and their brothers and their sisters and their friends and everyone that's got opinions?
Probably,
or do you mean
probably not.
A health professional?
A health professional.
Yeah.
I mean, the thing with like opinions, you know, are like assholes. Everyone's got one. But you need to, this is the hard thing, right? You can ask a health professional. So I'm a fan of people being in charge of their own healthcare journey. You need to be critical of the answers you're getting from health professionals. Because a lot of, particularly in domains that we don't understand, like if you sprain your ankle, you're going to have to find a pretty wacko health professional to get advice that might make you worse. Mm-hmm. People can miss fractures and you might do stuff that's a bit unnecessary or whatever, but you're going to be hard-pressed to find something that will actively make you worse. When we're in unpredictable domains like pain, it's really easy to get answers that probably make you worse. So that's the health professional level.
Yeah.
So if we take a step down and just not down in terms of the quality of the human being, but in terms of their understanding of medical things, and you start asking the general population, you're going to get most of the time worst case scenario. Or, oh yeah, my uncle's had a bad back for 20 years and his life's over and you should think about funerals and blah, 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 blah. Then you go another step down, you've got the internet. Google basically will tell you that you're dying, and anyone on the internet who is trying to engage in a conversation is not going to help you at all. And in fact, the same lady who, with the persistent ankle pain, she was searching for answers, which was great, but she was searching in Facebook groups for persistent pain people, and we were just talking about it. And there might be some, and I know of a couple. I'll give a plug to the one that is sort of looked after by Bronnie Lennox Thompson, which is called Exploring Pain and Meaning, I think it is. Like someone like that, that she's a great resource, and that group is, on the whole, quite helpful. You still get wackos in every Facebook group. Yeah. But she was in community-driven, basically just this is how I feel groups, and it's not a positive experience. So everyone feels shit. So if all the information you're hearing is that this is shit, that's going to have a negative. Yeah. I mean, I say this to people all the time. I don't need to tell you it's shit. Like you know it's shit. So I guess curating the information that you're being exposed to and understanding how that affects how you feel about it, and then that affects how you actually feel it. But fundamentally, if you don't understand it, then someone can help you understand it.
Yeah.
Even if they can't make it go away forever, if you understand it, then you're in control of it.
Yeah.
Rather than it controlling you, for sure. And lots of it goes away. Lots of it goes away. Just because it hasn't doesn't mean it can't.
That's cool. I like that. Where is a good resource for clinicians or patients, but predominantly clinicians, for the topic of this to go to learn more about this?
Well, after just trashing the internet, go to the internet. So again, this is where it comes down to curating the sources of your information, right? So there are lots of people who know a lot about pain, and but funnily enough, because I've done this a lot over the last 10 years especially, but even the last 20 years, when you start looking into, again, inverted commas, pain experts, because they don't exist, you realise that even the ones that are meant to know everything disagree fundamentally around what pain is or isn't. So, like, if we don't even know what it is, when we're starting to work out what works around it or what treatments are the best, we're just on shaky ground.
Yeah.
So I think it's important that researchers are looking at what it is and where it comes from so we understand it better. But I think at a grassroots, like coalface, mix my metaphors with people in pain, having an in-depth understanding of exactly what it is probably doesn't matter that much. In saying that, I personally have found, so we'll go to anecdote land, the more you understand about it as a process, the easier it is to convert that into conversations with someone around their pain that helps them understand it, because it gives you more flexibility. So based on how they're responding, if I've got more information, like some sort of pyramid type thing, if my base is bigger, then different peaks are easier to go to.
Yeah.
And if I'm more confident over a wider range of topics around pain, then different conversations around it are easier. So I don't know where the best is, but all I can tell you of what I've done over the years, I've done the NOI group's Explain Pain course. I've done lots of stuff with Ben Cormack. I've done Greg Lehman's course. I think as a young clinician, I think that's probably one of the best ones to do from a grasping where to begin or how to approach it, finding a process. I think that's a really good fundamental one. Bronnie Lennox-Thompson, as I said, I think she's fantastic. Lars, and forgive me, Lars, if you're listening, I can't pronounce your last name, Ava Murray. I think that's how he says it. He's an angry man. He'll probably come and chase me down. And then I guess that's probably the other thing, is realising that all of those options are quite recent, but pain research has been around for years. Like, it's funny when you look online and someone's like, oh, this new pain science stuff. Pain science has been a thing since the 1950s. So we're currently using Louis Gifford's 3 books to prop up our microphone. Louis Gifford, Melzack, and now I'm going to forget his name, which makes me sound like a real rookie. I've forgotten his name. I'm going to Google it while I talk at the same time. There's heaps of stuff in the background, but Louis Pat Wall, that's it. Louis Gifford's books are, particularly that Aches and Pains one, they're a really good way to get a handle on at least a place to start. Because it is confusing and it's complicated. But again, you don't need to know everything about pain to be good at helping people with pain.
Yeah.
Definitely.
And the Future Health Network?
Of course. Plug myself. Why not? I guess so the plan for this year with courses is to, rather than, it's not an explain pain course. It's not come and learn about pain. It's come and learn how to develop a process, and not our process or my process, but your own process around how to approach it, and how to develop these networks and systems so that you're making less mistakes, and then how to apply it practically in the clinic to give yourself more chance of positive outcomes. Mm-hmm. So it's a bit more practical in the sense of it's not what it is, but how to do it, I guess, is probably the...
Which I think is the missing part with a lot of the other courses around pain. So we'll share that and post that on the podcast page when that's a thing as well. Cool. Any closing words?
I don't think so. I don't have any.
He says that to me every time, and it throws me on the spot every time, and I never have anything to say.
Well, I should have some catchy catchphrase, but I think those things that I've, as I said, like the things I end up in with most of the time are knowing more about it is helpful to be better at doing it clinically, but you don't have to know everything. Mm-hmm. And remember that the people who know more than you don't know everything either. And some of them are going to be wrong when we understand more about it. So confidently step into what you don't know. And remember that the things that have the most effect on whether you're going to be successful with actual people in the clinic, how much you know about pain probably isn't even in the top 10, 5. Mm. It's the stuff that you're already good at and you're getting better at each time, and you just tinker with your process, and as you go, you get better. So don't let what you don't know about pain stop you from what you do know about helping people.
And people with chronic pain are still just people.